All right, so ECG, I'm not going to repeat much of what you already know in terms of the basic structure of an ECG, but the waves there. But some things I just want to point out here will be, so I want to start first with the ischemic changes first, and then we'll look at the abnormal readings and how to diagnose them properly. So at this level, what are the things we want to know for maybe ischemic changes, MI, and things like that in the heart? You want to be able to identify, right, when there is an acute coronary syndrome in the heart. We want to be able to identify the location which leads are affected, and you're going to find out that the leads correspond to the surface of the heart that's undergoing ischemia as well, so that we have to know. And then we have to know, correlate that to the anatomy of the coronary blood supply, basically, which artery supply the surface of the heart. So what an examiner can do is give you the ECG for somebody that experiencing an MI, and you're going to identify which leads are affected, and then use that. They're going to ask you an anatomy question, right? Like which arteries like you put there based on that, things like that. So those are going to be important things we want to know. So the first thing is, let's just look at the basic anatomy, like the blood flow, and then we're gonna dive into more details. So if I'm looking at the heart like this, because basically in the chest, the heart kind of sits this way. So we have the inferior wall of the heart. So basically the base, and you have this lateral wall here, which corresponds to the lateral wall of the left ventricle. And of course, we have this, assuming this is your left side, this is the right side. The head is here, the legs down there. And on this right lateral surface, definitely that will be the right ventricle. Lateral wall typically corresponds to the left ventricular wall and the apex of the hand. And then anterior wall, or we call it anterior septal, yeah, corresponds to the anterior wall typically of the left ventricle as well. So we have two major, right, branches of the coronary artery, right and left, right, coronary artery. And of course, there's a wall I'm not showing right now, which will be the posterior wall. So there's anterior septal, but of course, on the other side, that's going to be the posterior, right, wall of the heart. So right coronary artery supplies, and this is going to be basic just to have an idea. Right coronary artery supplies, of course, the right ventricle. Inferior wall is supplied by the right coronary artery branch called the posterior descending artery. The posterior wall also typically right coronary artery branch, which is the PDA. Anterior septal is going to be branch supplied by the branch of the left coronary artery, which is the LAD. And the lateral wall is supplied by the branch of the left coronary artery as well, which is the left circumflex artery. So that would be the basic plus of I want to know, right? Right coronary artery supplies right ventricle, goes posteriorly through the PDA, posterior descending artery, and then ends up supplying the inferior wall. The left coronary artery will supply the anterior septal, mostly the head through the LAD, left anterior descending, and then the lateral wall will be left coronary artery as well, which is through the left circumflex artery. There's something we call right dominant, right? Or left dominant coronary blood supply. In other words, which coronary artery is the dominant one is the dominant artery. So the way you're going to know is the coronary artery that gives rise to the PDA, the dominant coronary artery. Coronary artery that gives rise to the posterior descending artery is the dominant and it is the right coronary artery in about 80% of people in the population, up to 85%, while in 15% of the population, they have a left coronary artery dominant circulation, where the PDA comes from the left coronary artery, right? So that is something else to keep in mind. Okay, so we know the surfaces of the heart, we know the arterial supply, which leads, ECG leads, right, correspond to that. Remember, the goal of doing an ECG is to figure out the conduction, right, in the heart. Is the electric connection working well? Things like that. And we can also find out some other things like is the muscle, are the muscles bigger, are they impacted, things like that. So we have, based on how we place the leads. So if I'm looking at somebody's chest, for instance, like this, and I have my manubrium, I have the sternum, I have for the second rib coming out here, first rib usually comes up there, you have your third ribs, fourth, fifth, sixth rib, right? On that side, this is my right side, this is my left side, person's head up there, and their legs up here, down there. So we have leads, we have leads on the limbs, leads we're going to put on the limbs, and then we have leads on the chest. So the standard 12 lead ECG, right? We're going to have leads placed on the chest. So typically what we do is, so remember, this is my first rib, second rib, third rib, fourth, fifth, sixth. So in the fourth intercostal space, fourth, on the right personal border, right, we usually have B1 here, and then B2 is usually placed here. Fourth intercostal space, right personal border. Then we usually go to the fifth intercostal. So on the fifth intercostal, mid-clavicular line. Mid-clavicular line, you have your B4. So which means B3 will be between these two. Somewhere in the midline between B2 and B3, B4. And then if you keep going laterally, fifth intercostal space, you go laterally like your anterior axillary line, you have your B5 lead, and then mid-axillary line all the way to the side here, you still be the fifth intercostal space, you have your B6. So you just place it like that. So you start from the side, personal body on the right, B1, B2, B3, B4 mid-clavicular line, mid-axillary line, fifth intercostal space, B5, and then you have your, anterior axillary, and then mid-axillary, right? B6, so anterior. Then we also have some leads on the limbs, right? So on my right upper extremity, we have a lead called BR. So we can say, so this on our right side, it's gonna be on the right upper limb. So we're gonna have the AVR, we call that AVR lead on that side. Then you have also another lead on the left upper extremity, which is what we call the AVL, right? Basically, A means for augmented lead, right? And then on the legs, left lower, because you're gonna have your left lower leg, sorry, right lower leg here, left lower leg there. Then we have another lead on the left, only on the left lower leg, not on the right. We call that AVL. Sorry, AVF, F for foot, AVF. So AVL, AVR, AVF, right? So we are still missing how many lead? We're missing 3 because this is a 12 lead ECG. We have 9, but we're missing 3. So the other 3, they are called leads 1, 2, 3. And lead 3 is usually what is based on the location, it's looking at the inferior wall. So I just put lead 3 here, like inferior. Lead 1 usually looks, lead 1 usually goes on this side. And then we have lead 2 as well. Let me put this, let me write this properly. So lead 3 here, inferior but closer to the right side. then lead 2 inferior but closer, right, to the left side. So these are the locations of your leads. So far, so good?
Yeah.
Okay. Now, where's the heart? So let's draw it like a sketch of the heart. The heart, of course, will be somewhat located like this in the chest. That's what we have on the left side, or let's put that here as well on the right. So let's say that's the heart there in the chest. What do you notice? So if I ask you which leads are looking at the inferior wall, which leads are directly looking at the inferior wall of the heart based on their positioning?
Like lead 2 and 3.
The 2, 3, and remember AVF. Remember the AVF on the left leg as well. This one, this one, this one, this one. Make sense?
Yeah.
So 2, 3, AVF, inferior wall, leads or inferior leads. Okay. Which leads are looking at the anteroseptal wall of the heart?
Like maybe V1, V2, V3, and V4.
Thank you very much. V1 to V4, anteroseptal. Which leads are looking at the lateral wall?
Lead 1, LVL, and AVL.
AVL. Remember, LUL is like left upper extremity. I just want to point that the lead there, the AVL, right, is located on the left upper extremity, right? But it's not a lead. You get it? Yeah. So, but it's just giving my idea of where the location, what the location is there. Okay. So one AVL, what else?
And V6 and maybe V5.
V5, V5, and V6. Okay. So far so good.
Yeah.
Okay. And then which lead is looking at the right lateral wall? The right ventricle.
That would be AVR.
AVR. And which leads do you think are looking at the posterior wall?
Maybe like V1, V2.
Okay. So, but are they looking at posterior wall directly? No, right? Remember, they are looking at the anterior wall directly.
Yeah.
But the posterior wall is the mirror, imagine like mirror image of the anterior. Does that make sense? So whatever I see on V1 to V4 in anterior MI, I'm gonna see the opposite, like the reciprocal of that, if the patient has posterior. Does that make sense? Make sense?
Yeah.
Right, because the leads are not looking at it directly, but of course, inverse, there'll be like an opposite, almost like a mirror image of what we expect to see, right, on the anterior. Okay, nice. And that's important to note. Now, based on the blood supply, doc, although we don't have a lead, right, looking at the posterior wall directly, right? But because the blood supply, posterior wall has blood supply in common to which other locations? Posterior wall has blood supply in common with the other locations.
Inferior wall.
Inferior wall, as well as the right lateral wall, right? Right ventricle. So which means I can, if I see inferior wall MI, I can predict that our patient also has posterior wall. Does that make sense? Because it's the same artery that supplies both of them. Does that make sense?
And right ventricle too.
And right ventricle too, yes. Does that make sense or not? Good?
Yep.
Okay. So we know the walls, we know the blood supply, we know the leads. that correspond to that. And this is basic ECG, right, for ischemic changes. This is what we want to know. So if you're thinking posterior wall, be thinking of the right coronary artery, PDA, reciprocal leads will like B1 to B4, or I can insinuate that it's posterior wall by looking at the inferior leads. Done. Oh, right ventricular, right coronary artery. AVR is the one looking at it directly, but I'm going to show you something else that we can do to look at the right ventricle soon. And then I'm thinking lateral wall, 1 ABL, B5, B6, left coronary artery, true left circumflex supplies that. Inferior wall, RCA, PDA, specifically, 2, 3 AVF. Yeah, looking at that. So I can quickly transition. If I'm giving the wall and asking about the leads, I'll get it right. If I'm giving the leads, asking about the wall, I know. If I'm giving the wall, I'm asked about the blood supply. If I'm giving the leads, I'm asked about the blood supply. You can go back and forth. So the example typically will give you one. They're going to ask you about any of the other two components that we have written down. Right. Okay.
So the best thing to do in the exam is like draw it out, and then you could easily.
Yeah, you can draw this out. You can have this part of your cheat sheet for the exam.
Mm-hmm.
Yep. So what else can I do to look at what the lateral, to look at the right side? So what I can do is look at our precordial leads, the leads on the chest, the B leads. I can actually put them on the right side because the way they are now, they're on the left side. So sometimes if we suppose somebody has right ventricular MI, we can reverse these leads, put them on the right side. So instead of having your V2 now will now be V1, V1 will now become V2, and then your V3 will now be placed here. Basically the opposite, the same location as it was on the left, but on the right side, between the V1 and the V4. You're gonna place V4 here now, which will be mid-clavicular line on the right. You put your V5, you put your V6. So basically and now we'll now call this right, V6, right, V5, right, B4, right, B3, right, B2, B1. So if a patient has right ventricular MI for sure, I'm going to see it very clearly on like B4, B3, B2, and stuff like that if I reverse the leads to the opposite side of the chest. Yeah. So that's something else we could do. But you can always still insinuate, right? That there's likely a right ventricular infarction or posterior wall MI from looking at the inferior wall, since they all have the same blood supply. Make sense?
Yeah.
Okay. Now, let me add some other things here. Our pacemakers, SA node and AV node, right? They are supplied by what? So just some additional information to know. SA node, AV node, they're supplied by RCA primarily. And then you have your bundle branches. Typically, the left bundle branch usually supplied by left coronary artery. So this is why sometimes to in patient with right coronary artery infarction or MI, you're going to see what you might see sinus bradycardia, or you might see heart block on ECG because of what concomitant SA and AV node is ischemia or infarction in that person, because they're supplied also by the RCA. And the patient with left coronary artery infarction, you might see evidence of left bundle branch block on ECG, right, because it's also supplied by the by the LC, right? So you might see like widening KRS complex like that. So these are just some other additional clues that might tell you which artery, right? Okay. Now let's take a step. So we know the lead location artery. What will I see? What am I looking for in ECG to tell me that what patient is having an infarction or ischemic changes? So let's go to the next.